we're gonna. Good morning, everyone. Thank you so much for joining. I am Drs Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston and the director of the MFM Fellowship at Tufts. Super excited to join you today, and always with the editor-in-chief of AJOG MFM, Dr. Vincenzo Berghella. Vincenzo, nice to see you.
Good to see you, Mo. Good morning.
So for those of you who are not familiar with our format, we select 4 articles that we want to highlight for this month's issue. We're highlighting June 2026. Here are the articles listed here. We try to select papers that are of robust study design or also have a strong clinical interest and applicability to caring for pregnant patients in the office or on the labor floor. And we try to select papers that are not only applicable to our MFM colleagues, but also to every provider who's taking care of patients, whether it's our generalist colleagues, family medicine docs, nurse practitioners, PAs, nurse midwives. For everyone, we're hoping this will be helpful. We are doing visual abstracts to provide a high-level overview, but we strongly encourage you to read the articles in detail on ajogmfm.org. And with that, Vincenzo, why don't you start with our first paper?
Yeah, thanks, Mo. I love doing these reviews with you. So this one is from Justin Brandt group up in New York, Strategies for Pregnant and Postpartum Transgender Men and Gender Diverse People Assigned Females at Birth in MFM. And this is, a super important topic. And we always ask as editors at AJOG MFM kind of to summarize the articles also from the papers, and here's what the actionable strategies they suggested to create gender inclusive spaces. And we've had quite a few patients like this, and it's really, really important to make sure if there's somebody that for example, has a beard or is bald or, doesn't look like a woman in the waiting room. I think it's important to be mindful of language choices for ultrasound results and counseling as well, to get better patients ready, to do individualized delivery planning, to support infant feeding goals, to monitor closely for depression and mental health problems, which are more common in this population, and for comprehensive contraception counseling. These are delightful patients to take care of, I find, very committed to their pregnancies. And like the summary you put here at the bottom, it's we need to ensure that all people with potential to become pregnant and give birth have access to inclusive gender affirming care. And again, we found in our experience, you need to make sure people are aware and are appropriate in their attitudes at the front desk, nursing, NSTs, ultrasound, sonographers, students, residents. There are so many people that help. People who want to get pregnant, that are pregnant, have their babies, that it's really important to help them. And I love the flag in the background there.
Yeah, this was a really great summary. It has a lot of information really for all aspects of interactions with patients throughout their pregnancy experience. So highly recommend everyone read that in detail. There's a lot of tips and tricks of how to best serve this patient population.
Let me dedicate it, I'll make an exception. Let me dedicate this one to, I know he doesn't mind, my transgender man nephew, who is in a reproductive age as well, and my fingers are crossed.
Thanks so much. Our next paper is by a study group based in WashU. This is comparison of community level deprivation indices and their association with adverse pregnancy outcomes. So there is a lot of work trying to identify an index that can look at an area with different geographic units and different community level factors to try to identify which based on where someone is living and their environment or neighborhood, what is their risk of an adverse pregnancy outcome? So there are 3 indices most commonly used right now: the Social Vulnerability Index, Maternal Vulnerability Index, and the Area Deprivation Index. They each use different factors. They each have a different geographic unit. And there are, different papers using different indices, and no one quite knows which one might be the best to apply for pregnancy. And so that's what this group aimed to evaluate. They did a secondary analysis of a prospective study from their center, and using these 3 indices, tried to see which one was most associated with adverse obstetric outcomes, neonatal outcomes, and also looking to see if they were modified by race, which we know is often used in identifying risk for adverse pregnancy outcomes. What they found was that the Social Vulnerability Index, when it's high, which means a low community resilience, that is most commonly associated with adverse obstetric outcomes. The other 2 indices were not. None of the indices were associated with adverse neonatal outcomes. And the SVI was not modified by race, which was nice to see. Unfortunately, none of the indices had a very good predictive capability for actually predicting the risk of adverse obstetric outcomes. And so this might be because it seems to be on a geographic level that's very challenging to identify, what someone's risk is just from where they're living alone. It's not necessarily the right unit. And so I think there's really a search for a better community level measure. How can we identify someone's risk for adverse pregnancy outcomes based on where they're living and the other factors involved? And can we use that to properly identify, who is at most risk, who needs those services, and go from there? So more work to be done in this really important area.
Next one, it's on factors associated with appropriate administration of magnesium sulfate for neuroprotection prior to early preterm birth. It's really important to have magnesium on board when you delivered before 32, 34 weeks. It's not always possible. We try to get to as close to 100% as possible. And this paper kind of reviews this center in New York, large center in New York, about what factors associated with appropriate administration for MAG for neuroprotection. You could see it's a retrospective cohort study, singleton gestation 23 to 31 and 6, and that's what the BEAM study covered. Compared those who received the MAG and those who unfortunately did not, and found that actually 83% got it. So I think that this center should be praised. That's pretty high level. You always want to aim for protection, but 83% I think is pretty acceptable. And the reason for omission, especially the first one, was somewhat understandable, delivering less than 2 hours from omission or acute fetal compromise, something that happens very quickly. Mm-hmm. Dr. Rouse, who wrote the largest trial, always taught me, it's important to have the MAG on when you deliver. You can stop it if you don't think they're going to deliver, restart it later on, but really important. So it's kind of a reminder to us that if you have somebody who comes in and has something acute, or the strip doesn't look good, if you're worried, I think this paper says kind of be on the conservative side, start magnesium, and you can always stop it later on if things look better a few hours later. Also, another reason for omission of magnesium was omission for abnormal fetal status, omitted for non-obstetric diagnosis, and lack of adherence of protocol was uncommon, like we said. So they concluded a rapid delivery rather than non-adherence is most common reason for omission of magnesium sulfate for neuroprotection. And again, maybe we need to come up with even better predictive, kind of algorithms for rapid delivery. But sometimes it's just impossible to predict. Very important paper, with a few things that work in preterm birth to improve the health of the baby, in particular steroids and MAG, and giving them to the appropriate people. It's so important.
Absolutely. And our last paper is another paper from the group at WashU. This was looking at stage 1 hypertension before 20 weeks gestation and the association with postpartum outcomes. And so, stage 1 hypertension, which is defined as a blood pressure between 130 to 139 over 80 to 89, that is not formally included in the definition of chronic hypertension in pregnancy. But there certainly is some data coming out that patients with stage 1 hypertension do have risks that we need to be mindful of. And so, particularly for this group, they wanted to answer the association with postpartum adverse outcomes. This was a secondary analysis of a retrospective cohort study where they looked at patients who had stage 1 hypertension before 20 weeks of pregnancy versus those who were completely normotensive. And they found that in the group with stage 1 hypertension, they were more likely to have hypertensive disorders of pregnancy, and that supports prior data as well. Importantly, there was a much more likelihood of having the need for antihypertensive at 6 weeks postpartum, which I think is really important. They also had a over 10%, I believe, went into stage 2 chronic hypertension at 6 weeks, so blood pressure over 140 over 90. And a number of them also had readmission for postpartum hypertension disorders of pregnancy compared to the normotensive group. So I think it's important, even though it's not part of the formal diagnosis, I think this paper is providing more data that this is still a high-risk population. This is a population that is going to need that counseling, close postpartum surveillance, and really be mindful that these patients are still at risk. Just because it's not meeting the diagnosis criteria right now, I think this is still an at-risk population that warrants further surveillance. And that's all we got for this month. So thank you everyone for stopping by. Vincenzo, nice to see you as always.
As always, Mo, thank you. Thank you, and everybody for listening. And a really wonderful paper, so important, the topics. And thanks also not only to the readers and to the audience, but to the authors who continue to send such great work, to AJOG MFM. We thank you really all from the Pink Journal. Have a great day.
Thanks. Bye, everyone.